Hello, hello everybody. Good morning, afternoon, evening. There's so many participants and there's still many coming. I'd like to welcome you all. My name is Doreen Thomassen. I'm the coordinator of ShareNet International. And as a knowledge platform on sexual reproductive health and rights, we are very proud that together with our members and RedOrange, IPPF and their member associations, we can support the work presented today and this webinar, Breaking the Silence on Infertility. Welcome. I want to briefly take you back to how this all came about. Being a network, we bring our members, and those are practitioners, researchers, and policy makers in all the diversity together to forward the SRHR agenda and to achieve better and longer lasting results. And in order to do this, ShareNet goes hand in hand with co-creation, creating together. And during our first co-creation conference, or as we call it, CCC, in 2019, one of the two thematic tracks chosen by our members was on infertility. And today, we will hear more about the work on infertility that was initiated at that co-creation conference. And for us, this is an exemplary result of co-creation and our work at ShareNet. During the conference, participants agreed that there is a need for advocacy tools and materials to break stigma and taboos around infertility. There is a need for more openness, to recognize grief and encourage people to ask questions, speak up about infertility. This resulted in a twin project. Breaking the Silence on Infertility has two legs. It has a policy brief and a series of videos. The policy brief includes practical examples for policymakers. Hopefully in this big audience, there are many advocates, perhaps also policymakers from different regions who will make use of this policy brief. But also a series of videos which include personal stories from 3 countries, Bangladesh, Burundi, and Jordan. Some of these beautiful and touching stories will be shown today. So all this work, it was initiated during our first co-creation conference in 2019. This year in July, we'll do it again. Already our 3rd co-creation conference, co-organized by one of our newest hubs, ShareNet Colombia. And this year, the focus will be on access to quality SRHR information, which of course should include information on infertility. I'd like to welcome you once again. For those who just come in, please enjoy the webinar, participate as active as possible online, and stay engaged. Also with ShareNet, you may want to consider engagement through membership or reach out to us. If you feel we should explore a closer partnership, you can find us on our digital platform, and my colleague will show you in the chat how to go there. Then I would like to introduce you to a very dear colleague, Masuma Bila. We know Masuma from RedOrange Media and Communication, a Dutch Bangladesh development agency and our host organization for ShareNet Bangladesh. And there she is. Masuma is the head of research and innovation, a trained demographer and researcher leading the research and innovation team at RedOrange. Please, everyone, mind that in her role as moderator today, she will be deciding about our speaking time and terms. She's our boss of today. Masuma, I hand over to you now.
As moderator, let me welcome you all in today's session. I'm joining from Dhaka. Good evening from my end. Before going to the main session, I have some housekeeping information, and I will describe briefly how we are going to organize our 1.5 hour session. So I will not take much time. I will take 1 or 2 minutes to let you know the housekeeping information. The main language of today's event is English, and we have translation facilities to Spanish, French, and Arabic. Let me start by recognizing that even though we have translation facilities today, but we could do more to be inclusive in our online event to ensure that people with all abilities can follow the conversation and engage. Unfortunately, we did not manage to have sign language today, but we are keen to make the experience meaningful for all the participants. And in that spirit, I would request our honorable speakers to describe their settings before they speak. You can start by describing how you look and from where you are, etc. So that vision impaired colleagues, the colleagues with the vision impairment can also follow us. And you know, this is an event on infertility and reproductive health and rights, which are grounded in human rights, tolerance and acceptance. To be able to create a safe and inclusive space, we do not tolerate offensive remarks to the speakers and anyone from the audience. We are keeping the chat and Q&A option open during the session for the greater engagement with the audience, but we'll stay attentive and intervene if any attendee violates our rules, values, and principles. Please feel free to drop your comments and questions on the chat or in the chat box or in the Q&A box. We have separate Q&A box. There's the icon on Q&A. You can drop your comment and questions there. The event will be recorded and we will share the recording shortly after the event. And we are also grateful to have Medhabini, our colleague. She is basically the graphic facilitator, joining us today to truly help us to break the silence, stigma, anger, and shame associated with infertility and women's bodies. She will help us visualize the conversation today and capture the outcomes creatively. We'll call Medhabini towards the end of the session to show us the progress of the mural. This event is an opportunity to learn about the burden and stigma associated with infertility and about people's personal experience of how infertility impacts their life. The webinar will present the outcomes of the collaborative infertility awareness projects supported by ShareNet International and implemented by many others, including IPPF, WHO, RedOrange, and ShareNet members. In order to inform our conversation on evidence and practices, and stories, we have a variety of speakers joining today and participating in the 3 segments of our event. In our first segment, we will hear from WHO, IPPF, and colleagues from the Infertility Community of Practice convened by ShareNet to set the scene by briefly presenting their problems, around infertility from a right-based and a sustainable development approach. Secondly, in the second segment, we will hear from the countries. We'll hear the stories derived from research, community engagement, and service delivery from our partners in 4 countries, Burundi, Jordan, Bangladesh, and Colombia. And finally, we'll go to an interactive discussion session with our speakers on what has been presented, including where young people fit in this conversation and in this discussion. We want to hear you and your questions on the topic. So please feel free to post your question in the Q&A chat box. We will direct those questions to the speakers during this session. We'll put the links to the project outcomes, the short videos from Burundi, Bangladesh, Jordan, and the policy briefs. We invite you to use those tools for advocacy and action on infertility in your own community. Ladies and gentlemen, now we'll go to the main session. Today's first presenter the presentation will be delivered by Dr. Gitao Buro, World Health Organization. He's from the World Health Organization. Let me introduce briefly Dr. Gitao, and then we'll go to the presentation. Dr. Gitao is a specialist of the Department of SRHR and Research of WHO in Geneva, Switzerland. You know, the WHO's SRH department provides global leadership on matters related to sexual reproductive health and rights through shaping the research agenda, contributing high impact research, setting the norms and standards, articulating ethical and human rights-based approach, to reproduction and supporting research capacity in low-income settings. Let me welcome Dr. Gitao again. The floor is yours, Dr. Gitao. Thank you.
Thank you very much indeed to you for the opportunity to participate and present in this important webinar. We've been invited from the World Health Organization to provide an update on policy and programmatic guidance, and we thank you again for the invitation. Next. Infertility is defined as the failure to achieve a clinical pregnancy after 12 months or more, or regular unprotected sexual intercourse. In 2004, the first DHS comparative report on this issue indicated that there were 186 million ever married women of reproductive age in developing countries who were attempting to conceive and failing. In 2012, an analysis of household data from 277 demographic health surveys concluded that there were 48.5 million couples who were living with infertility. We have a significant amount of evidence showing the burden of infertility and particularly its negative impact on quality of life, gender inequality, and mental health. There are many reasons why we should be focusing on fertility care, but I just want to highlight a few in this slide. The first is that there is obviously an increasing tendency for delaying childbearing globally that we have witnessed, but this is happening within the context of age-related decline in fertility, as you can see on the right side of this slide. However, awareness of fertility potential remains fairly low in many different countries. And therefore, it is likely that we are predicting that it is likely that more individuals will require assistance to reproduce in the coming years. Many causes, of course, of infertility are also preventable, so it makes a lot of sense to invest in public health prevention before diagnosis is achieved. Although infertility is a medical diagnosis, it is obviously not, in many countries, prioritized within health policies, within services and financing systems. And this is leading to disparities in access, and many individuals and couples are spending quite a huge amount of their money on out-of-pocket for fertility care. Consequently, there are three key consequences that we are seeing out of this. One is that there is catastrophic expenditure at household level, leading to persistent household poverty and debt. Number two, there is tendency for people to go for cheaper, less safe, and less effective treatments. And thirdly, there is a preference for multiple embryo transfers and multiple births. And multiple births are associated with poor outcomes in terms of maternal and neonatal health.
Mr. Gitao, we are using translators, and they have a bit of difficulty to catch up with your speed. So if you could try to talk a bit slower, that would be helpful. Thank you.
Thank you very much indeed. So at the World Health Organization, we are focusing on a number of areas to respond to fertility care globally. And I just want to take a little bit of time to highlight those. One is in terms of policy. And in this regard, we have two key aims. One is to support the development of global guidelines, which is currently in progress. And this will be cascaded from the global to the national levels and subsequent monitoring implementation at the country level. The second key aim around guidelines, around policy, is the support to member states to ensure there is inclusion of infertility in national policies. And we have seen very good progress in this regard, with a number of countries being able to prioritize infertility within their national sexual and reproductive health and rights policies, such as Thailand and South Africa. The prioritization of infertility within sexual and reproductive health paves the way for public provision and financing, as we have already seen in a number of countries such as Morocco, Rwanda, and Argentina. And we want to encourage countries to be able to do so. Another key area of work that we are supporting in terms of policy is the development of policy frameworks that provides an environment for safe provision of fertility care, for example, in Ghana. Next. Within WHO, another program of area of work that we are supporting is on data and strategic information. And in this regard, I just want to highlight the work that we are doing to update the estimates for prevalence of infertility globally and regionally currently. The last prevalence estimates were produced in 2012, which you can see on this slide. And currently, the process started in 2019 when we commissioned reviews of published studies on infertility. We held a technical consultation in 2021, in which we looked at the interim results, and we are hoping that we'll be having new estimates by the end of this year. Next. A third area of work which I want to highlight to participants today is on monitoring and indicators. Currently, we are using prevalence mainly as a main indicator for monitoring and tracking progress in terms of infertility and fertility care. In 2021, we commissioned a review to look at all indicators that are used globally, and found that there are over 100 indicators in use in over 87 countries around the world. However, these indicators mostly relate to efficiency and effectiveness, and there is a significant gap in terms of indicators that focus on safety, equity, patient-centeredness, as well as timeliness. Another key significant finding from this landscape analysis is that the use and reporting of indicators varied widely between countries. In some cases, the reporting is compulsory, and in other cases, it's not. It's completely voluntary. And therefore, the aim of this work is to make sure that we have a core set of priority indicators that can be used to monitor progress on fertility care around the world. Next. Finally, I would like to just take a minute to briefly expound on the work we are doing to expand awareness and education on infertility, because there's a clear need to ensure that infertility is understood by all stakeholders as a serious condition that requires both medical and social interventions. In 2019, the World Health Organization launched the very first fact sheet on infertility. We are working with a range of different stakeholders. We are also looking at the possibility of supporting the community of practice to be able to support this thematic area. Next. So finally, I'd like to conclude with three remarks. First is that WHO recognizes infertility as an essential component of sexual reproductive health and rights, and it has important and significant global impact on a number of key outcomes. Number two is that World Health Organization is working on a number of activities which have been highlighted in this presentation, and we are hoping to continue fostering collaboration with different stakeholders on this area. We thank the organizers for this webinar, and we would like to continue emphasizing that we need to break the silence on infertility. That's all I have time for. Thank you very much indeed. Thank you.
Thank you, Dr. Gita, for your nice presentation, very informative presentation. We are already a little late time-wise, so I will not go for the detailed brief for the next presenter. I will just introduce the presenter for the presentation. Our next presenter is Dr. Mary Thoma, and she worked with Ellie Limhas in a project, and she'll going to present this work today. Dr. Thoma is a reproductive and perinatal epidemiologist, had worked focusing on infertility, birth spacing, and pregnancy outcomes. And let me tell something about Ellie Limhas. She worked with Dr. Thoma with this project. Ellie Limhas is an international SRHR advisor. She is with us today. And she's a member of the COP, Infertility COP of Netherlands. Floor is yours, Dr. Thoma. I believe our colleagues will introduce you more elaborately in the chat box. Thank you. Floor is yours.
Thank you so much, Masuma. And welcome everyone. And thank you to ShareNet and IPPF for the opportunity to share our policy brief on addressing infertility within sexual and reproductive health, a commitment to human rights and sustainable development. And to follow along with the presentation, you can find a link to our policy brief in the chat. So our goal for today is to provide you with an overview of how this policy brief can be used to advocate for action to address infertility and engage policymakers in these discussions to ultimately break the silence on infertility. Next slide. Our aim in developing this brief was to make it adaptable to different country contexts and needs. So with that in mind, we recognize that different countries may have different starting points for engaging with policymakers on infertility. And we structured the policy brief around 3 goals that reflect these different points of engagement, which were set up to provide language that can be used to start the conversation, information that can help to identify steps toward action, and finally, ways that programs or policies might be implemented. Next slide. To To start this conversation with policymakers and other stakeholders, we underscore the integral connection between addressing infertility and infertility-related stigma and reproductive rights, that all couples and individuals should have the right to decide the number, spacing, and timing of their children, and the information and means to do so. And that if we are to make progress on SDGs, we need to be thinking about their connections with infertility, as shown in this figure and outlined in the policy brief. Next slide. We also highlight key messages that can be readily communicated to stakeholders to engage them and initiate discussions. Next slide. For countries in which policymakers are already interested and invested in this issue, but who want to figure out where to focus efforts, we outline 5 priority areas to strengthen programs and policies, which include increasing public awareness, providing data systems to monitor infertility, enhancing prevention programs and fertility care and treatment, making sure to include psychosocial programs to support couples and individuals dealing with infertility, which are too often forgotten. And finally, strengthening research and public health infrastructure and regulation to support these initiatives. Within each priority area, we emphasize strategies for fostering stakeholder engagement, developing education and training, and expanding advocacy and implementation. Next slide. These strategies are further detailed in Table 1 of the policy brief under each of these domains. And here I just highlight a few examples in which to engage, educate, and advocate for greater public awareness and education on infertility. In addition to outlining these strategies, we wanted to showcase what countries are already doing to address infertility, to emphasize to policymakers that this can be done and how it might be implemented. That is why in Table 2, we provide country-level examples with hyperlinks and references for you to access. And here I've just highlighted a few examples from Table 2, including ANARA, a new IVF data monitoring system in Africa, a national action plan developed by the CDC in the US to enhance public health infrastructure and research on infertility, and Pro Familia, which you will hear more about later in the webinar. And an example of raising public awareness is a featured video developed as a knowledge product during the ShareNet co-creation conference. And this video features voices from different countries to raise awareness on infertility and infertility-related stigma, which I'm happy to introduce to you now.
هي بالنسبة لنظرة المجتمع قاسي كثير، إنه كل ما حدا يسألك إنه قديش صرتي جايبة، قديش صرتي محوشة، إنه لما تحكي لا لسه.
ما أجاني يعني أنا ما أجاني خلفة من عام من تاريخ زواجي اللي هو 96 ولغاية 2020.
আমার বিয়ের 2 বছর পর আমি জানতে পারলাম যে আমি আর কখনো মা হতে পারবো না।
baribarutse twararose abana mugabo rero mu nyuma zaho maze kubyara umwana agira kane naciye mpura n'ibibazo byinshi mpura n'ingorane nyinshi.
قبل فترة أعطوني تقريبا 12 فحص طبي، رحت فيه على مختبر طلب مني 400 دينار، فأنا ما معي أصلا يعني ربعه هذا المبلغ.
كل جندي أو كل عسكري مسموح له 3 محاولات، وعملت زراعة في عند الأخصائيين على حسابي نفط خاصة. متعب موضوع الزراعة، متعب مش للرجل، بالنسبة لنا يعني قناعتي الشخصية المرأة، يعني أنت قاعد تحكي عن حوالي 50 إبرة، وحتى بعد الترجيع تحكي عن أمر المنيقون ونهب مويعات وكلكسان، موضوع مزعج.
duce turagenda ku kigo ABF turacitura nahone bongera gupima bace baravuga ati by'ukuri hariyo kansera. Rero twebwe nta kindi tubona kuri ABF bonyene bace barandika ikete bace baratubwira ati aha ani mugende kuri kwivuriro ry'abasoda hajya kuri hôpital militaire. Mu muryango w'umugabo nta muntu n'umwe yasuye kunkunda, niwahora nkunda ntiyasubiye kunkunda, niwahora aza ngaha akaraba abana ntiyasubiye kugaruka ngaha, kandi byateye bikomera no ku mugabo wanje।
কে আমার স্বামী আমার শ্বশুর বাড়ির পক্ষ থেকে অনেক চাপ ছিল যে তাদের একটি সন্তান প্রয়োজন। এক পর্যায়ে দেখা গেল যে আসলে তাদের সন্তানই প্রয়োজন, আমাকে আর প্রয়োজন নেই। এরকম হতে হতে আসলে এক পর্যায়ে আমি আর পারছিলাম না, আমরা আলাদা হয়ে গেলাম।
علاقتي في الحقيقة هي مش علاقة طبيب في مريضه، هي علاقة فيها أنا بستشعر قديش هذا مريضي بيشعر بمعاناة وعنده مشاكل تنتج عن موضوع إنه ما في طفل في البيت. صراحة المشكلة قد تبدو لكم منها بسيطة، لكن هي مشكلة عظيمة، مشكلة متجذرة تدخل حتى على مستوى الصعيد النفسي للعائلة، على مستوى حتى الثبات الأسري، على مستوى حتى النسيج الاجتماعي، فإلها تداعيات كبيرة. وأكيد بتعرفوا إنه بيزداد العنف الأسري وتزداد المشاكل إذا ما كان في طفل في البيت.
Au Burundi, les gens ne pensent pas que c'est un problème qui ne peut pas être résolu, que ça peut être lié à de la sorcellerie par exemple ou à des malédictions, qu'il y a souvent, dans la plupart des cas, des causes qui peuvent être identifiées et des traitements qui peuvent être offerts. Que le problème d'infertilité au niveau de la communauté burundaise est très complexe, parce que c'est lié aux valeurs de masculinité, c'est lié aux valeurs de patriarcat, c'est lié à tout ce qui se passe au niveau de l'héritage. Donc c'est très complexe.
ঢাকা শহরে কিছু চিকিৎসা থাকলেও বাংলাদেশের অন্যান্য ঢাকার বাইরে অন্যান্য জায়গায় কিন্তু এই চিকিৎসা খুবই অপ্রতুল। এই চিকিৎসা ব্যবস্থাটাকে আমরা ডিসেন্ট্রালাইজ করতে হবে। এটা ইনফার্টিলিটি কেয়ারটা যে চিকিৎসার যোগ্য এই সচেতনতাটা মানুষের ভিতরে আমরা গড়ে তুলতে পারি এবং সেটা আমরা এখনই করতে পারি।
muri ubu buzima bwanshikiye ntabwo byoroshye cyane, ni ibintu bikomeye, ni ibintu bisaba gusenga cyane, gikuru ni ukwihangana.
Okay, thank you. And now this policy brief and video were meant to be shared, and we have developed a dissemination plan, also linked to in the chat, with guidelines for outreach to organizations, providers, and individuals. And we call on all of you to become active, engage, and speak up about infertility. Next slide. The time is now, and infertility is everywhere, and it intersects with our current global health challenges, including COVID vaccination campaigns, which have been derailed due to myths that vaccines cause infertility. It also connects to our ongoing global climate crisis, with research showing the impact of climate change on fertility and pregnancy outcomes. And so I will end where I started, in that greater investment to address infertility and related stigma will not only support our sexual and reproductive health and rights, but also support sustainable development and the health and well-being of our global communities. And thank you for your attention, and we look forward to further engagement with you on these issues.
Thanks a lot. Thanks a lot, Dr. Thoma. It was really an informative presentation, and the video touched me personally. I believe it touched the audience as well. So we'll go to our next presentation. That will be the last presentation of this segment. I will call upon our next speaker, Ms. Natalie Kapp. Natalie Kapp is an obstetric gynecologist from IPPF. She is currently the Chief Medical Advisor of IPPF based in London. Her research is primarily focused on methods of contraceptive and abortion, and she has more than 60 peer-reviewed publications. The floor is yours, Natalie. Thank you.
Thank you so much. I'm really grateful that we can all be part of this webinar today. And I just have a few comments. At International Planned Parenthood Federation, we see infertility care as an integral and essential component of sexual and reproductive health care. For instance, in 2019 and 2020, we provided between 2 and 3 million infertility services globally. 72% of our service providing member associations globally provide some degree of infertility services. Many of these provide counseling, consultations, referrals, and investigation or workups. And those who provide interventions to treat infertility makes up almost 60% of our member associations. An important issue that we see in infertility services is that, like HIV and abortion, it can be very stigmatized. Stigma affects women and girls and their male partners, providers, as well as reproductive rights advocates and communities. Although infertility is not an uncommon experience around the world, it is still largely stigmatized. Negative attitudes and beliefs may act as barriers to accessing services and can make it difficult for people to talk about their experiences. This can be very isolating and negatively affect people's mental and physical well-being. From our extensive work on stigma at IPPF associated with abortion and HIV, we have found that developing guidance and tools to help messaging and raise awareness decreases stigma. And this is why we're here today to break the silence on infertility. And with that, I'll turn it back to Masuma.
Thanks a lot, Natalie. We are now at the end of the first segment. We heard from colleagues from WHO, IPPF, and ShareNet COPs. Now we'll go to the second segment. As I told, we have heard the global perspective on infertility. Now we'll touch upon the real life stories from countries. The country representative will demonstrate to us the powerful role of local and grassroots advocacy to materialize the global agenda on SRHR, including right-based, affordable, non-discriminatory access to quality infertility services and care. So in that point, I will call upon the country representative one by one. Our first speaker in this stage is Dr. Donovan Wimana. She is the Executive Director of the Burundian Association for Family Welfare. Dr. Donovan is an expert in public health, especially in SRHR, maternal health, newborn health, infant and adolescent health. She is an advocate of SRH and women rights with 17-year working experience in Burundi. The floor is yours, Dr. Donovan.
Okay, merci beaucoup.
I'm extremely sorry.
Thank you.
Donovan will speak in French, so you can avail your translation facilities. Thank you, Donovan.
Okay, merci.
Thank you very much. I will briefly talk about the context in Burundi, and I will be focusing mainly in the link between infertility and cervical cancer in Burundi, because IPPF is an organization that works mainly in incidents around parent planning, Planned Parenthood, and we work mainly on infertility issues. And we have tried to garner a number of stories coming from different women that talk about their situation. We have different stories that concern different women, some of them who have different causes for their infertility. We have young women that have cervical cancer, and that with the treatments that are available, finally led them to a more radical treatment that ended up making them infertile. So I wanted to talk about the treatment given to cervical cancer. And in Burundi, as well as many other countries in Africa, we detect and treat very late the cervical cancer and have access, a reduced access to specialized services. And we know that there is a national context that has greatly focuses on family, and this is pressures people into having children. So we were trying to work into the relationship between cervical cancer and infertility, but in this context, it is mostly related to the treatments that are available nationally. And if these cancers would have been detected earlier, we think that many women could have been treated and not become infertile. So in our country, regarding treatments, we don't have a lot of possibilities. And many of young women, in the interviews we've had with them, talk about their situation. And one of the speakers whom we talked was 28. Dans un tel contexte, in such a context, it's important to share the causes of infertility and the different causes that can be that are sexually transmissible and that need research. And in that way, we have shared this story that we feel is a good representation of what is happening.
Et les conséquences au niveau social sont très dramatiques parce qu'elle va subir le stigma. Voilà, qu'elle est déjà...
Dramatic. She had children before, but she will be stigmatized anyway. So that helped us satire the public's interest about the taboo in the communities and reinforce public policies.
Thank you. Thanks, Dr. Navin. Thanks for your nice presentation. I tried to follow the interpretation. I believe that the audience also followed the interpretation as well. So I will go to our next presenter. In that point, I will call upon Dr. Mohanta Garibe. She is a professor from Jordan. Dr. Muntaha is a professor in maternal and child health. At present, she is the Dean of the Faculty of Nursing at Ahliya Amman University in Jordan. She is the former Secretary General of Jordanian Nursing Council, and she is a member of the Jordan COP on infertility. Floor is yours, Dr. Muntaha.
Thank you, Masuma, very much, and thanks for Sharnet and IPPF for the invitation. I think we're all excited for the presentation and what we're going to hear. I'm talking about Jordan Initiative. Next, please. Next slide. Jordan has taken so many initiatives so far, and in relation to strengthening infertility services and awareness. One of the most important initiatives is integration of infertility in the National Reproductive and Sexual Health Strategy for 2030. This strategy, we'll talk about it. And the second initiative is we have a COP on infertility and national community of practice. And we have members of the community who participated in the policy brief and the development of the video. The third initiative is dissemination and advocacy through the National Infertility Community of Practice on the issues of infertility. Finally, the issue of accreditation standards that we pushed for to include infertility follow-up on the newly emerging initiatives on women-friendly health center in Jordan. Next, please. In relation to the national strategy, I think what we have done is very much similar or integrate some of the recommendation of WHO. The strategy has 4 strategic goals. I think one of the most important goal is to provide inclusive, integrated quality of sexual and reproductive health information and services. Within that goal, there are one action to develop a standardized national sexual and reproductive health service packages covering all adopted sexual and reproductive health components, including one of these service packages is on infertility. It's also important to say that this is the first strategy in Jordan that took the lifestyle cycle. So infertility is integrating the concept of lifestyle when it comes to adolescent, also on awareness on reproductive health. One of the most important things is, again, one of the recommendations of WHO to look at indicators and follow up for monitoring. This strategy has developed a new impact indicator to measure the success on infertility issues. And this indicator, it's defined as marital infertility. This is a new indicator that has been created specifically for infertile couples, and it's conducted every 5 years, and it's going to be integrated within the national population and infertility study every 5 years. So this is a national indicator which all sector has to be part of collecting data on. Next, please. Next. The second initiative is, we participated in the development of the policy brief as a member, and my colleague, Dr. Ahmad, has participated in the video development, whom you have seen as the military guy. So the military services are very strong on integrating infertility in their services. So the process of as members of the COP, and again, WHO talks about developing community of practice for infertility, which we did in Jordan. It's a new initiative that has been developed under the umbrella of the High Population Council. And it's also important to remember that the High Population Council is the entity that developed the national strategy on reproductive health, and they are the hub for the ShareNet. So the strength of really moving forward in Jordan, it's not relying only on the government or the private sector. We have an organization that takes care of this, and they are the ShareNet Jordan itself. Next, please. Again, we have in Jordan recently, we have a new initiative called Women's Friendly Health Centers. And there is an organization that looks at these centers and looking at certain criteria and packages of services and who can be a member of healthcare professional in these centers. It's an initiative that had been developed by the UNFPA, where they want to create standards for accreditation of these health centers, and they are primary healthcare centers itself. And they are linking the initiative with the Accreditation Council. So the High Health Council, the UNFPA is collaborating with the Health Accreditation Council in developing these standards and start implementing the accreditation of these centers. What we are doing right now as a policymakers and as a push toward infertility integration, we identified infertility as one of the service packages to be implemented there. Therefore, there should be an integration of the standards issues on the quality of services provided for this. This is a new initiative, but hopefully we'll be managing lots of efforts to integrate infertility. And finally, I just want to say that most of the initiative we're taking right now are progressive, are concrete, are direct. What we're going to be doing next step is to really take the video and the the policy brief and move forward. And I think we have created an awareness so far among academics and researchers, whom most of them are attending with us today on the issue of infertility. There is a huge amount of research. Next, please. There's one final thing. That's all. But I think finally we are progressing very well. We are in line with WHO recommendations, and I think we will be moving forward very soon when it comes to decisions, and we will probably talk about challenges later. Thank you once.
Thank you, Professor Muntaha, for your presentation, and I'm excited to hear the progress that Jordan already has made. Thanks a lot. As I just want to remind the participants that you can drop your questions or any asking in the Q&A chat box. I can see quite a few questions. If you have any specific question to any speaker, you can also write this in the chat box. So our next presenter is from Bangladesh, Dr. Syed Sheikh Imtiaz will present now. Dr. Imtiaz is the former chair of the Department of Women and Gender Studies, University of Dhaka, Bangladesh. He is the chairperson of the Center for Men and Masculinity Studies, CMMS, as well as the honorary chair and trustee board member of the UN Youth Student Association of Bangladesh. The floor is yours, Dr. Imtiaz.
Thank you, Masuma Appa. Good evening from Dhaka. I am sure you all are okay during this COVID-19 pandemic. I am just a COVID survivor, so please forgive me if I do anything, if I forget anything in between. By the way, first of all, what I would say, where are we? Next slide, please. Next slide, please. The first slide. Yeah, thank you. So where are we in Bangladesh? What I see as a researcher and practitioners in terms of all these numbers, I mean, we really don't have any concrete study to really tell you what is the exact rate of infertility. So there is a huge gap, research gap. The data that you are observing in the slide, all these data are collected from different secondary sources. So there is no research study. So there is a huge data gap, the first thing. The second thing is the mainstream attitude is that this country is already overpopulated. So population is a problem here. So you understand that it is very obvious that among the policymakers, infertility is already marginalized. It's not at all an issue. And there is also the concern where we see people thinking of fertility. Infertility is not also a public health problem. So in case of Bangladesh scenario, there are two things. One, infertility is not at all a concern in our country among the policymakers. And two, infertility in general is not at all an issue, even at the societal level. So it's more at the individual level. So this is the Bangladesh scenario. The next slide, please. Yeah. So now, as I said, when we, as part of this COP, we conducted an empirical study, and we did consultation with the policymakers and also with the people who are suffering from infertility. We found that and in the general population, in general, the knowledge regarding infertility is very, very low. So people really don't understand even what infertility is. And those people who are even suffering from infertility, they also don't have any idea unless they go to the doctors, especially the men. Men are not aware about infertility. Women seems to be more concerned about infertility, and men or as partner, even where we found that the men have a problem, even they are not very much knowledgeable about the infertility issue. The second thing is this lack of knowledge actually leads to inadequate service-seeking behavior. So we don't find people to really go and treat infertility unless it is a huge societal problem for them. And with regard to infertility treatment, Bangladesh has only one infertility treatment center which is public, which is a government, which is set up by the government, and the rest are, which is again very few, are very costly and situated only within Dhaka. So outside of the country, you don't find any treatment facilities. The big concern that we found during the study is related with the younger generation, and we found that the lifestyle issue is a very big issue. Those couples whom we interview who are between the age of 30 and 40, we found that most of them are actually suffering for infertility because of their lifestyle. The other issue is also definitely the socio-economic discrimination, especially with regard to LGBTQ people. People don't even consider, in most cases, these people are not even considered as human beings. So their issue of infertility is not at all discussed in anywhere, even in case of the doctors. When we talked with them, some of them also were surprised about this issue, that even hijras or third gender people can be treated for infertility issues. The other thing is definitely infertility is a gendered issue. So all the burden with regard to infertility, you find that it's women who are the primary victims. As you see in the video, the women was talking about it, that how it has created burden for her in her household and also in the community. But interestingly, as we see from the other women probably from Burundi, talking about the link between infertility and patriarchy and masculinity, and we found men, whenever they are identified as infertile, society consider as if their manhood has gone. So infertility has also a very close connection with being man, and that's where I think an opportunity lies for us to intervene and also make men aware about infertility in the society, so that the taboo can be reduced. So next slide, please. Next slide. So in our study, next slide, please.
Dr. Imtiaz, sorry to interrupt. Your time is over, so yeah.
Yeah, very quickly, can I just say the recommendation?
Yeah, wrap up as quickly as possible.
Yes, please, the next slide. That's the last slide. Yeah, recommendation. So we recommend that we need research, we need quantitative data about the size of infertile population within the country. We need to sensitize the population, and also we should focus on prevention, especially with regard to lifestyle problems, and integrate counseling, and also consideration of adoption might be one of the way for those who are already who cannot be treated. And also we need to develop a guideline for Bangladesh, which should be part of the national policies on HRHR issues. So thank you very much. Yeah.
Thank you, Dr. Imtiaz, for your intensive presentation. I'll go to the next presentation quickly. I will call upon Dr. Carlos to present Colombian experience. Dr. Carlos will talk about his activities and his involvement with the clinic of Profamilia in Bogota. He was there. He was like associated with Profamilia since inception. Floor is yours, Dr. Carlos.
Well, thank you very much to IPPF and ShareNet for the invitation and opportunity to talk to you in this webinar, Breaking the Silence of Infertility, about our Profamilia experience. Next, please. Profamilia is an IPPF and ShareNet associate. We're working now for almost 55 years. Next, please. We are a non-profit organization founded in 1965. Initially, we focused on family planning and gynecologic services for low-income population, but as a natural development of practice, we get to have the fertility consult very quick. So we promote as an institution the availability and affordability of fertility services, and we are focused on maybe three main ways to work through promoting legal reforms from policymakers. We have the collaboration, a very close collaboration with national health authorities as the health minister here in Colombia, and also we are a member of scientific societies promoting knowledge and education to other doctors working in the fertility and in the gynecology and in human and sexual reproductive services. Next, please. In the 80s, we have the first fertility counseling and very basic diagnostic workshop. Of course, we don't have the techniques of the capability for developing new treatments. In the 90s, we started to make some low complexity treatments as intrauterine inseminations, homologous and heterologous. And in 2003, we started to work with high complexity treatments, making this unit for treatment of infertility. We are a multidisciplinary group. We have the first inclusive services for same-sex female couples here in Bogota, almost in Colombia, open that field for that people needing help. We also have developed a very efficient and low cost form of the study, the diagnostic tools for very precise, very sharp diagnostics and promoting the low cost, the almost more affordable treatments for all the couples that need that. Next, please. In 2080, we started the infertility prevention programs that will move in different ways as education to the public, general public, as in radio, TV shows, magazines. We also have talks and courses with insurance providers, with doctors that working in gynecology, teaching them how to not to delay the studies or delay the treatments for the people. We work with medical associations promoting meetings and conferences, and also on social media postings, trying to reach and get to the more people that we can reach in this way. In 2020, as the pandemic came to Colombia, we have to implement and have a very good program in telemedicine consultation, because we are aware that we cannot delay treatments with the low impact that we will have as age of the females will go on and our results will go down and have a bad results for them. And in 2022, we are moving toward new programs as fertility preservation, maybe both by social reasons or oncology reasons. We are moving to establish our transgender health services. So as you can see, we are moving, reading the audience, reading the population where you live, and of course, supplying all the needs that our population, a specific population in Colombia, we are needing. Next, please. We have to thank you, and I'm going to present now a video with our experience here in Colombia. Thank you very much.
How many people fail to become parents spontaneously? Thousands of couples and single women want to have children, but face certain difficulties. Infertility is a condition that can hinder that dream, and for many people, it is an unknown topic. Helping to educate and raise awareness about this disease and accompanying thousands of people who suffer it is part of who we are. We are Pro Familia Fertility. 18 years ago, we opened the door for thousands of people in Colombia and other countries who require counseling, support, fertility treatments and preservation. Now, our duty is that each person has the best care and access to these with the highest quality standards. On this path, we also fulfill dreams and reach more people in the Colombian territory. Thus, in the city of Cali, we opened the second fertility unit in the country in 2011. Our team is made up of 13 specialists in different fields who are educated not only in new and better techniques, but in respect, defense, and protection of all people. Biologists, embryologists, infertologists, trained nurses, and psychologists work day by day to achieve the goals of their patients. These last 2 years were even more challenging, and although a pandemic stopped the world, we never stopped. Every day, we strive to implement processes of education, prevention, research, advocacy, and the provision of fertility-related services. Because being human is the first step in caring for others. From the virtual world, we have amplified the voices of our specialists with lives, webinars, conversations and talks in the media, social networks, and academic scenarios. Because achieving that every person enjoys their sexuality and that their human, sexual, and reproductive rights are guaranteed is part of what we are. We are Profamilia, the leading organization in sexual and reproductive health in the country.
Thank you very much, Dr. Carlos, for the nice presentation and the nice video as well. I'm going to the third segment of the event. It's a question answer session. Before going to the final segment of the event, I would like to thank all the speakers for the intensive research and work you presented in front of the audience. Before going to the Q&A session, I would like to introduce our youth representative. We have a youth speaker today. So Rawan Raj is our youth representative today, a medical student and SRHR and youth advocate. She works at the Institute of Reproductive Health and Rights, and she's a coordinator of the Sudan SRHR network. I have a question for you, Rawan. How do we address the burden and stigma of infertility, including prevention and working with the young people? Do you please respond?
Hello, thank you. First of all, I would like to thank you for introducing me and for inviting me to be part of such an important conversation in such an important and often neglected topic. Total reproductive choice and autonomy should encompass both the ability to prevent, delay, and stop a pregnancy, yet also the ability to start it, yet prevention, treatment, and diagnosis of infertility remains absent from conversation of reproductive health and SRHR in general. What I would say is a way that we can address the burden of the stigma and work with young people regarding infertility is through 3 main points, through education in general and specifically through advocating for the inclusion of infertility treatment and comprehensive sexuality education, and for pushing for more youth-friendly reproductive health services and health services in general, and also through meaningful youth participation in infertility programs. For education, I think education at all levels and at every opportunity is, of course, a step first that can lead in prevention. Education is needed for young people to create behavioral change, and for providers and practitioners to create a practice change, and for policymakers to create a beneficial health policy and social policy as well. And as countless of young people grow up misinformed about their fertility and infertility, I do believe that we should push and advocate for introduction of sufficient fertility education as part of the curriculum in schools and as part of the comprehensive sexuality education, as we should stop infantilizing young people and we should trust them and empower them to make informed decision about their reproductive future, whether that was on either side of the coin, be it contraceptives or conception. Yes.
I think I will take the response from another speaker, Rawan. Can you explain your opinion in the chat box? Can you type it for us?
Sure thing, definitely. Yes.
Thank you, Ron. We'll come back to you if time permits later on. I will call upon Dr. Geeta if you have any response to this specific question.
Thank you, Masuma. Can you please repeat the question again, please?
So we just wanted to know that how you address the burden and stigma related to infertility, including the prevention and working with the young people.
Yeah, I mean, I think there are a number of strategies, and as we've already heard from different presenters, stigma is really preventing people from help seeking, and it's really disproportionately affecting women in many communities. And there are 4, maybe 5 key strategies that I'd like to propose. One is that we need to ensure that we increase education and awareness to make sure that we are shifting the prevailing social norms around infertility, because we cannot move forward in terms of addressing a stigma unless we are able to educate people and make sure that they understand some of the misconceptions that go around infertility. The second area is that we emphasize that to be able to respond to stigma, we have to increase the availability of treatment. Because if we increase the treatment to many people and everyone who requires treatment were able to get it, then we will be on a journey that gets people to understand that actually it's not such a bad diagnosis, it's not a bad condition, because you can get treatment with it and you can actually recover, you can on your journey to childbearing. The third area, I think, which we've already mentioned today, is the whole issue of creating spaces for conversations. And in many countries, we've seen that there are no patient support organizations. There are no peer support strategies. Most people who have infertility suffer in silence. They don't actually have any kind of support mechanisms around them. And therefore, whether it's formal or informal, we feel that it is important to make sure that we have those safe spaces for support for people to find other people to talk to. Patient organizations tend to be very good. There are a few good examples that we've seen in some countries, but in other countries, really, there is no formal patient support organizations.
Thank you, Dr. Geeta.
Around fertility. And finally, we need to, I think there's been research which has shown clearly that help seeking is very low, especially in many countries. And I think this point has been made around whether people seek help, especially for men. So we also need to work around strategies to make sure we support people to seek help. Thank you.
Thank you, Dr. Geeta. I have another question. I have quite a few questions. I will try to, ask the questions as much as possible. Rest of the question will be answered with our speakers later on. I have one interesting question. So the question is, what are the top strategies that Ministry of Health can take in different countries to address infertility? I think Ellie, you want to respond on it?
As Ellie is thinking, maybe I can just make a quick contribution because we are always in constant dialogue with ministries of health and to them to prioritize. And there are our key asks normally is to say, we need to prioritize infertility within national health programs and sexual and reproductive health and rights. And number 2, we need to make sure that we produce national strategies that respond to infertility. And within those national strategies, there are a number of key areas which we normally would say to ministries of health they are well positioned to do. One of them is to convene stakeholders, bringing them around the table to make sure they have a national strategy, make sure you have guidelines in place, make sure that you support the inclusion of infertility within national health insurance and social protection or financing schemes. Make sure that you include the medicines and diagnostics that are used for fertility care within national essential medical lists, because this is also a problem. And finally, I just want to emphasize that ministries of health are really well positioned to make sure that there is quality standards and regulatory frameworks that can create an environment where fertility care can be provided safely. So there are many.
I do agree with you, Ms. Dr. Geeta. They are in the right position to respond. Ellie, you want to respond?
Yes, I would like to add to that indeed the Ministry of Health is key, but before you are able to enter the door in the Ministry of Health, you need to do a lot of preparatory work, find your allies, because you as an individual will unlikely get access to the minister or the director of reproductive health. So please find your allies, get together with the stakeholders and make some noise before the ministry will open its ears and start working on it. So I fully agree with you, Gita, but I think there's a lot more work to be done. We are extremely happy that we have a couple of ShareNet hubs, but we have IPPF virtually all over the world, and there are a lot of allies with us. So find them and get together.
Thank you, Dr. Ele. Yeah, I'm totally agree with you. I will go to the second question, Dr. Muntaha. I will come to you. I have a specific question for you, I think. My question is, do you think cost is a barrier to infertility treatment and programming? I want Dr. Carlos to respond on it.
Excuse me, I missed the question.
Do you think the cost is the barrier to infertility treatment and programming? Briefly, please.
Okay, in our country, of course, and I think in almost all of the developing countries, the cost is a very important issue, since these treatments and studies are not covered by the social security systems. Here in Colombia, for the first time a few years ago, maybe 2 to 3 years ago, the Constitutional Court determined that infertility is a disease and have to be covered by social security. But the congressman hasn't made any legislation to make that law applicable to the law, to the health system providers. So the diagnosis is done, the law is made, but the legislation is not yet ready. So the people have two ways: or make a litigation against their insurance, and there's a lot of time and emotion consumption in that way, or to involve in personal expenses to get the treatment done. So that's the very important thing about being very efficient and being very sharp in the diagnosis and promoting the most effective treatments, individualizing the treatment for each couple.
Thank you, Dr. Carlos. Dr. Muntaha, I have a question for you. I just want to know, what are the challenges addressing infertility and what is the status of establishing women-friendly health centers? And if you touch upon how Jordan deals with the taboo around infertility. I have limited time. You have to answer briefly.
I think I do agree with Eli on the role of Ministry of Health, who they don't have the priority. They don't have this is one of the challenges when you have a private sector that's taking care of all the infertility treatment, and the cost is very high. We're not talking about equity and rights here. And I don't know what was the main things to start orienting the Ministry of Health and creating. And what we did in Jordan actually is the ShareNet in collaboration with the Higher Population Council has done this power to push toward the government to start thinking of integrating this in the reproductive and sexual health. I don't know what was the rest of the question. I think the stigma is there. If you are in a country where you don't have resources for healthcare, except for priority healthcare issues, which is reproductive health and fertility, then it becomes really very important to shift the gear toward infertility and convince the government. However, we are succeeding. The Women-Friendly Center is a new initiative, and we are finding a blessing to integrate everything in that initiative with UNFPA. Thank you.
Thank you, Dr. Muntaha. Definitely, Jordan is showing the way, path, and other countries can follow Jordan's model.
Thank you.
I will quickly go to Dr. Sheikh Imtiaz. Dr. Imtiaz, are you with us?
Yeah, I'm with you. Yeah, please.
Imtiaz bhai, I have a question for you. So can you just explain very briefly what are the good ways to reach men with information and infertility? And tell about Bangladesh experience, how we can reach the men.
I mean, it's very quickly. First of all, you will have to speak. I mean, there is no such initiatives where you where men are addressed at all. I would really thank IPPF. Whatever I found, all those are done by PAB Bangladesh. So first thing, to me, it is some people should speak up about the taboo, and the way we have found it is to integrate within the existing yard meetings on different issues, including sexual and reproductive health rights issues. Whenever we have brought the issues, it seemed to us that men are not at all initially ready to listen. But when you speak about it, then they started to open up themselves. So it also requires very focused and targeted intervention. That's what I can say very briefly. Yeah.
Thank you. I will take one more question because time is up. I have the last question to Dr. Gitao. I think Dr. Gitao is the right person to respond. So how we can, how WHO is trying to integrate infertility services with other SRHR services?
Thank you. The short answer is yes, we should integrate infertility within other reproductive health services. And the main point to be made is that infertility needs to be seen as an essential component of sexual reproductive health services. It's not an additional service that you're bringing into SRH space. It is actually meant to be an essential component, and that's WHO's message, and we need to do that. Thank you.
Thank you very much, Dr. Kitao. I will quickly go to my colleague, Medhavini's desk. Medhavini, are you ready? So I just want to know more elaborately how Medhavini prepared for us the whole conversation. Let me quickly check whether Medhavini is here with us.
Yeah, give me a moment. I am ready actually, but can I share my screen? First of all, thank you for making me a part of this very informative webinar. I try to cover as much as I can in visual format in my ability. I have jotted down the main points like stigma and affordability around infertility. Also, I have jotted down the country stories. This is still work in progress, and I'll share the final drawing via email to everybody.
Thanks a lot, Medhavini.
Masuma, we do have a little bit of time to take a couple of questions, so we can take a couple of questions, and Medhavini can send us the updated illustration.
Yes, thank you very much. I will take, I think, 2 more questions. I have a specific question for Dr. Mari. Can you just respond? Do you think that presenting videos and action tools helpful to work with the young people awareness and also for the awareness of the entire population?
This is something that we did discuss in the policy brief too, around really focusing on dispelling these myths and addressing infertility within the youth population. And I think this will translate even just with general fertility awareness, so those myths can be dispelled. I think the videos, one of our key priorities that we talked about in the policy brief was raising awareness. And I think that's where the videos are so critical to, and as Ellie mentioned, just to find your allies and advocates in this space. So yeah, I would say that, our point is to share these products that we've developed and really create more awareness across the spectrum.
I think we may have lost Masuma. Are you back?
May I add? Well, we try to get hold of Masuma. In the link, I see, for example, Jackie Bovin, who is also pointing out that there are more animations, and really we, as a knowledge platform, we can also help to share all the types of tools that are available, because not everybody is always aware of what is already around, and it's good to share. This could be a commitment from our side.
And I'll add that in our policy brief, that was also our kind of focus is, at least in the table 2, of compiling some of these examples, but please share the additional examples as well. Potentially we can update and incorporate it too.
Thank you, Dr. Mary. I will ask another question. I have another question. I can see the hands of Dr. Gitao. I will come back to the other question, and I think you can respond on it. Is it all right, Dr. Gitao?
Yes, of course. Yes.
Yeah, I have another question. The question is how we can create a safe space, like either through COP that allows for the exchange of information and education on infertility, and how can we join forces to the country level and the international level to respond on infertility. So Dr. Gitao, I think you're the right person to respond, and if anybody want to add with that.
Thank you very much indeed. I think,
after Dr. Gitao.
Okay, I just wanted to add on the point that was made by Mary, because the reason why it's so important to reach young people is because we know that awareness of fertility is very low amongst younger people. Most of the younger people don't see concern around infertility as something that concerns them. And in fact, research has shown that most people overestimate the ability of ART to solve their fertility problems. And of course, we think that it is better to have this information earlier so that people can make the right lifestyle choices. So we are really doing the right thing by making sure that we are focusing on younger people, because it also helps on so many other fronts, fertility planning, prevention, and so on. And on the point on the safe space, I think we've seen quite a few countries which have national fertility education programs. Even in Europe, I think the UK has done a very good job in terms of creating, I think Armenia does. And we need to make sure that we work to actually create those national fertility programs that are focusing on the general population and those at risk. It's a big investment, of course, but we have good examples that we can create. And we've already mentioned before the need for communities of practice. We mentioned the need for peer support and patient organizations. And of course, within this forum, I'm very pleased to see just the numbers of people who have turned up, because this is really how we are able to create those opportunities for sharing information and disseminating best practices. Thank you.
Certainly. Dr. Muntaha, very quickly.
I think one of the most important things is to create models of private-public partnership on issues of management of infertility to support, people under the umbrella of the lack of insurance. And the second important thing is when we look at infertility service packages, and I think we should push toward inclusion of these service packages under the umbrella of universal health coverage, as well as the health insurance system of the country. And that's because everything is, Dr. Carlos was talking about financial issues are the main important issues. Then when we provide, I think the stigma will be less, and they will be considered of a normal population within the health care system who can enjoy whatever services provided. Thank you.
Thank you, Dr. Muntaha. My final question to Dr. Donovan. Just let us know about your work on cervical cancer and infertility related challenges you faced, or any success like you want to highlight, just in one sentence. Dr. Donovan, yeah. So your work in cervical cancer and infertility, any challenges or anything you want to highlight for the audience?
Thank you very much for this question. In fact, in Burundi, the most important was to put infertility into the political agenda, to tell everyone that infertility is a subject that should be discussed within the national agenda, because they mostly care for the problems that affect the majority of the population. But the fact of listening to testimonies was very important. Our open door was contraception, but there we could also add the testimonies of women suffering from infertility in Burundi and in our context. The second challenge was to have men speaking, because in Burundi, male infertility is still a taboo. So that was a challenge. About cervical cancer in Burundi, we have a very young population, and this cancer is also among young people, and it's related to the possibility of early diagnosis and treatment, and the consequence is infertility later on in life.
Okay, merci.
Hello, can you hear me?
Thank you so much. Thank you so much.
Thank you very much to everybody, honorable speakers and the audience for staying with us for a long time. We had a rich set of friends from various parts of the world. Can you hear me clearly? Thank you. We appreciate your engagement with us and all the questions you raised. We apologize if we could not respond to all the questions. We'll collect the questions with wider interest, and our speaker will provide responses that we will circulate with the webinar recording. The large number of participation and the activities involvement through their question raised in the chat shows the dire need of breaking the silence around infertility worldwide. Can you hear me? I'm audible?
Yes.
Okay, together we can break the silence. Definitely we can. Together we can break the silence, speak up and act. We need to normalize the talk around infertility. I want to thank you all, the participants, above all the speakers. Together we will continue to inspire each other. I strongly recommend before you leave this session to watch the video and for all other people in the world affected by infertility, that we are no longer silent on infertility, raise awareness, combat the stigma and shame, and break down barriers for access to good quality SRHR services. Let us break the silence around infertility. Please enjoy Bangladesh video. Thank you very much for joining with us today. We'll meet soon again. Bye-bye.
আমার বিয়ের 2 বছর পর আমি জানতে পারলাম যে আমি আর কখনো মা হতে পারবো না। ওদিকে আমার স্বামী শ্বশুরবাড়ির পক্ষ থেকে একটা চাপ ছিল যে তাদের একটা সন্তান খুব প্রয়োজন। আমাদের সমাজের মনোভাবটাই এমন যে একটা মেয়ের কাজই শুধুমাত্র সন্তান জন্ম দেয়া, কিন্তু আমার স্বামী কিংবা শ্বশুরবাড়ির লোকজন তারা কখনোই এটা নিয়ে কারোর সাথে কোনো কথা বলে না, এমনকি ডাক্তারের কাছে যেতেও রাজি হয় না। তখন আমি মানসিকভাবে খুবই খারাপ একটা অবস্থায় চলে যাই। আমি আসলে বুঝতে পারছিলাম না যে আমার কি করা উচিত।
ইনফার্টিলিটি বা বন্ধ্যাত্ব বাংলাদেশে একটি বড় সামাজিক সমস্যা, বিভিন্ন কারণে হয়, লাইফস্টাইল, অকুপেশন, এই বিভিন্ন কারণে হয়, তারপরে জেনেটিক ডিসঅর্ডার, তারপরে আমাদের যে প্রজনন যে অঙ্গগুলো এগুলোর সমস্যার জন্য কিন্তু এটা হয়ে থাকে। ঢাকা শহরে কিছু চিকিৎসা থাকলেও বাংলাদেশের অন্যান্য, ঢাকার বাইরে অন্যান্য জায়গায় কিন্তু এই চিকিৎসা খুবই অপ্রতুল।
এরকম হতে হতে আসলে এক পর্যায়ে আমি আর পারছিলাম না, আমরা আলাদা হয়ে গেলাম।
সেক্সুয়াল রিপ্রোডাক্টিভ হেলথের যে গাইডলাইন আছে বাংলাদেশ সরকারের, তার ভিতরে যদি আমরা এই ইনফার্টিলিটি কেয়ারটাকে অন্তর্ভুক্ত করি একটা জিনিস। 2 নম্বর কথা হচ্ছে যে এই যে এটা ইনফার্টিলিটি কেয়ারটা যে চিকিৎসার যোগ্য, এই সচেতনতাটা মানুষের ভিতরে আমরা গড়ে তুলতে পারি এবং সেটা আমরা এখনই করতে পারি।
Thank you.